Chronic meningitis is an inflammation of the meninges with subacute onset and persisting cerebrospinal fluid abnormalities lasting for at least 1 month.
Chronic and recurrent meningitis. Introduction. Chronic inflammation of the meninges, pia, arachnoid, and dura, can produce profound neurologic disability and may be fatal if not successfully treated. The condition is most commonly diagnosed when a characteristic neurologic syndrome exists for greater than 4 weeks and is associated with a persistent inflammatory response in the cerebrospinal fluid, CSF, white blood cell count 5/L. The causes are varied, and appropriate treatment depends on identification of the etiology. 5 categories of disease account for most cases of chronic meningitis: 1. Meningeal infections, 2. Malignancy, 3. Non-infectious inflammatory disorders, 4. Chemical meningitis, and 5. Parameningeal infections. Clinical pathophysiology. Neurologic manifestations of chronic meningitis, Table 382-1, are determined by the anatomic location of the inflammation and its consequences. Persistent headache with or without stiff neck, hydrocephalus, cranial neuropathies, radiculopathies, and cognitive or personality changes are the cardinal features. These can occur alone or in combination. When they appear in combination, widespread dissemination of the inflammatory process along CSF pathways has occurred. In some cases, the presence of an underlying systemic illness points to a specific agent or class of agents as the probable cause. The diagnosis of chronic meningitis is usually made when the clinical presentation prompts the astute physician to examine the CSF for signs of inflammation. CSF is produced by the choroid plexus of the cerebral ventricles, exits through narrow foramina into the subarachnoid space surrounding the brain and spinal cord, circulates around the base of the brain and over the cerebral hemispheres, and is resorbed by arachnoid villi projecting into the superior sagittal sinus. CSF flow provides a pathway for rapid spread of infectious and other infiltrative processes over the brain, spinal cord, and cranial and spinal nerve roots. Spread from the subarachnoid space into brain parenchyma may occur via the arachnoid cuffs that surround blood vessels that penetrate brain tissue, the Urca-Robin spaces. Table 382-1 Symptoms and signs of chronic meningitis. Symptom sign. Chronic headache +/papilledema. Neck or back pain, Brudzinski's or Kernig's sign of meningeal irritation. Change in personality, altered mental status, drowsiness, inattention, disorientation, memory loss, frontal release signs, grasp, suck, snout, perseveration. Facial weakness, peripheral 7th CN palsy. Double vision palsy of CNS 3, 4, 6. Visual loss, papilledema, optic atrophy. Hearing loss, 8th CN palsy. Arm or leg weakness, myelopathy or radiculopathy. Numbness in arms or legs, myelopathy or radiculopathy. Sphincter dysfunction, myelopathy or radiculopathy. Frontal lobe dysfunction, hydrocephalus. Clumsiness, ataxia. Abbreviation, CN, cranial nerve. Intracranial meningitis. Nociceptive fibers of the meninges are stimulated by the inflammatory process, resulting in headache or neck or back pain. Obstruction of CSF pathways at the foramina or arachnoid villi may produce hydrocephalus and symptoms of raised intracranial pressure, ICP, including headache, vomiting, apathy or drowsiness, gait instability, papilledema, visual loss, impaired upgaze, or palsy of the 6th cranial nerve, CN, Chap 376. Cognitive and behavioral changes during the course of chronic meningitis may also result from vascular damage, which may similarly produce seizures, stroke, or myelopathy. Inflammatory deposits seeded via the CSF circulation are often prominent around the brainstem and cranial nerves and along the undersurface of the frontal and temporal lobes. Such cases, termed basal meningitis, often present as multiple cranial neuropathies, with visual loss, CN2, facial weakness, CN7, hearing loss, CN8, diplopia, CNS 3, 4, and 6, sensory or motor abnormalities of the oropharynx, CNS 9, X, and 12, decreased olfaction, CNI, or facial sensory loss and masseter weakness, CNV. Spinal meningitis. Injury may occur to motor and sensory roots as they traverse the subarachnoid space and penetrate the meninges. These cases present as multiple radiculopathies with combinations of radicular pain, sensory loss, motor weakness, and sphincter dysfunction. Meningeal inflammation can encircle the cord, resulting in myelopathy. Patients with slowly progressive involvement of multiple cranial nerves and/or spinal nerve roots are likely to have chronic meningitis. Electrophysiologic testing, electromyography, nerve conduction studies, and evoked response testing may be helpful in determining whether there is involvement of cranial and spinal nerve roots. Systemic manifestations. In some patients, evidence of systemic disease provides clues to the underlying cause of chronic meningitis. A careful history and physical examination are essential before embarking on a diagnostic workup, which may be costly, prolonged, and associated with risk from invasive procedures. A complete history of travel, sexual practice, and exposure to infectious agents should be sought. Infectious causes are often associated with fever, malaise, anorexia, and signs of localized or disseminated infection outside the nervous system. Infectious causes are of major concern in the immunosuppressed patient, especially in patients with AIDS, in whom chronic meningitis may present without headache or fever. Non-infectious inflammatory disorders often produce systemic manifestations, but meningitis may be the initial manifestation. Carcinoma 2 meningitis may or may not be accompanied by clinical evidence of the primary neoplasm. Approach to the patient, chronic meningitis. The occurrence of chronic headache, hydrocephalus, cranial neuropathy, radiculopathy, and/or cognitive decline in a patient should prompt consideration of a lumbar puncture for evidence of meningeal inflammation. On occasion, the diagnosis is made when an imaging study, CT or MRI, shows contrast enhancement of the meninges, which is always abnormal with the exception of dural enhancement after lumbar puncture, neurosurgical procedures, or spontaneous CSF leakage. Once chronic meningitis is confirmed by CSF examination, effort is focused on identifying the cause, tables 382-2 and 382-3, by 1. Further analysis of the CSF, 2. Diagnosis of an underlying systemic infection or non-infectious inflammatory condition, or 3. Pathologic examination of meningeal biopsy specimens. Table 382-2 Infectious causes of chronic meningitis. Causative agent CSF formula helpful diagnostic tests risk factors and systemic manifestations. Common bacterial causes. Partially treated suppurative meningitis mononuclear or mixed mononuclear polymorphonuclear cell CSF culture and gram stain history consistent with acute bacterial meningitis and incomplete treatment. Parameningeal infection mononuclear or mixed polymorphonuclear mononuclear cells contrast enhanced CT or MRI to detect parenchymal, subdural, epidural, or sinus infection otitis media, pleuropulmonary infection, right to left cardiopulmonary shunt for brain abscess, focal neurologic signs, neck, back, ear, or sinus tenderness. Mycobacterium tuberculosis mononuclear cells except polymorphonuclear cells in early infection, commonly 500 WBC/L, low CSF glucose, high protein tuberculin skin test may be negative, AFB culture of CSF, sputum, urine, gastric contents if indicated, tuberculostearic acid detection in CSF, identify tubercle bacillus on acid-fast stain of CSF or protein pellicle, PCR exposure history, previous tuberculous illness, immunosuppressed or AIDS, young children, fever, meningismus, night sweats. Miliary terabyte on X-ray or liver biopsy, stroke due to arteritis. Lyme disease, Banwartha syndrome, Borrelia burgdorferi mononuclear cells, elevated protein serum Lyme antibody titer, Western blot confirmation, patients with syphilis may have false positive Lyme titer, history of tick bite or appropriate exposure history, erythema chronicum migrans skin rash, arthritis, radiculopathy, Bell's palsy, meningoencephalitis multiple sclerosis-like syndrome. Syphilis, secondary, tertiary.
Causes. Chronic meningitis is usually caused by an infection. Many microorganisms can cause chronic meningitis. Among the most important microorganisms are bacteria that cause tuberculosis, Mycobacterium tuberculosis. C. Tuberculosis bacteria that cause Lyme disease. Borrelia burgdorferi. C. Lyme disease fungi, including Cryptococcus neoformans, Capsulatum, and Blastomyces.
Hi, I'm Rebecca Brayton and welcome to WatchMojo.com, and today we'll be learning more about meningitis. So what is meningitis exactly?
Meningitis is one of the most severe infections that occurs throughout our life. It's an infection of the envelope that surrounds the brain and the spinal cord.
Are there different types?
The two main types that we see are the viral meningitis, and those are seen more in the summertime, and they tend to be less severe as a group. And there's the bacterial meningitis, which are much more severe, and the consequences are much more present long-term for the kids or the adults who get this infection.
How common is meningitis?
We've had a lot of successes in the past with vaccines preventing the more common types. There's one type that persists called meningococcal meningitis, and these occur in about 300 kids or adults per year in Canada.
How is meningitis transmitted?
Meningitis is really bad luck when it happens to an individual. It's transferred from person to person, and it's through droplets, we say. So if you cough and you spray some very small droplets, the bacteria can be transported and aspirated in the other person in front of you. So it's through these droplets, or through sharing a glass, or older kids or adults a cigarette, they can get it from that.
Who would you say is most at risk of contracting meningitis?
It's really children under 5, especially under 1, and older teenagers and young adults are also at risk. And the university population of kids is also a group that has been noted as being at risk for this type of meningitis.
What are some signs and symptoms that we should look out for?
So the symptoms of meningitis initially can look like the flu, where children or adults will have a fever, they may have headache, they may vomit, they feel achy all over. So those are the initial symptoms. As the disease progresses, the more typical symptoms of a stiffness of the neck, of becoming very lethargic and tired, the headache becomes more severe, some individuals may go on to have convulsions, so those are the typical symptoms for meningitis.
I read something about a rash.
So with meningococcal meningitis, you can also have rashes that appear, and these look like bruises. So initially, when you have one, you think maybe I bruised myself, but then they can spread all over the body, and they can look quite angry, and it looks like a red purplish bruise.
What is the typical incubation period?
The incubation period from having been exposed to getting the disease is usually less than a week.
Tell us about some of the short and long-term effects of this illness.
For meningococcal meningitis, which is, like I say, the most common one that we see, 10% of individuals who have this meningitis will die. And these tend to die within 24 to 48 hours of the onset of the disease, so it's a very aggressive disease. Of the survivors, 10 to 20% will have long-term sequelae. These include neurological problems such as being paralyzed, becoming deaf, having seizure disorders. People will have school problems, attention problems, developmental problems, behavior problems. So those are the neurological problems that can follow meningitis. Some individuals will also lose a limb from having had meningitis because of the poor circulation throughout the body associated with this type of meningitis.
What are the preventative measures we can take to avoid meningitis?
The only prevention that we have is through vaccination, and there have been vaccinations that have been made available to the population in the past, And there are new ones that will be coming which will protect us against the more common meningitis that we see today.
And what about treatment options?
Treatment is fast medical care, intravenous antibiotics. Usually you end up in intensive care in a hospital. But even with all of those treatments, there still is 10% death and 10 to 20% of long-term sequela. So again, the best treatment is to prevent it, and the vaccines do a good job with that and have been shown to be safe.
If you get meningitis once, can you get it again?
Yes. So you can get it more than once in your life. So having had it once doesn't protect you from getting it again.
Great. Thank you very much.
Thank you.
Symptoms: headache, confusion, a stiff neck, and back pain are common. People may have difficulty walking, weakness, pins and needles sensations, numbness. Paralysis of the face and double vision are also common. Paralysis of the face, double vision, and hearing loss develop when meningitis affects the cranial nerves, which go directly from the brain to various parts of the head, neck, and trunk.
Viral meningitis is an infection occurring mostly in children under age 5. It happens when certain viruses invade the meninges, which are the tissues that cover and protect the brain and spinal cord. The meninges are arranged in 3 layers. The layer that actually touches the brain and spinal cord is called the pia mater. The spiderweb-like middle layer is called the arachnoid mater. The outermost and toughest layer is called the dura mater. Cerebrospinal fluid, which also protects the brain and spinal cord, flows between the meninges and over the surface of the brain. The most common cause of viral meningitis is a type of virus called enterovirus. Other viruses that can cause meningitis include the mumps virus, the measles virus, herpes viruses, and a variety of viruses spread by blood-feeding insects such as mosquitoes and ticks. Viruses that cause meningitis may be spread through the bite of an infected insect. However, the 2 most common ways the virus is spread are through fecal contamination, which can happen when hands are not washed after using the toilet or changing a diaper, and through contact with the body fluids from an infected person, such as through sneezing or coughing. Once inside the body, the viruses make copies of themselves and enter the bloodstream. Viruses travel through the bloodstream to the brain, where they cross the border between the bloodstream and the brain into the cerebrospinal fluid. The viruses spread throughout the cerebrospinal fluid and infect the cells of the meninges. The meninges become inflamed as the immune system begins to fight off the infection. Symptoms of viral meningitis in infants and young children include fever, irritability, loss of appetite, and trouble waking up. Symptoms in older children and adults include fever, headache, stiff neck, sensitivity to light, sleepiness, trouble waking up, nausea, vomiting, and loss of appetite. The symptoms of viral meningitis are similar to those of bacterial meningitis, but are usually less severe. Doctors may recommend acetaminophen or other nonsteroidal anti-inflammatory drugs for fever and headache. For meningitis caused by a type of herpes virus, doctors may prescribe an antiviral medication such as acyclovir. There is no treatment for most viruses that cause meningitis, though most people recover on their own within 2 weeks.
Chronic meningitis is slowly developing inflammation of the layers of tissue that cover the brain and spinal cord meningism of the fluid-filled space between the meninges subarachnoid space. When it lasts 4 weeks or longer, may infections and disorders that cause inflammation can cause chronic meningitis. Having a weakened immune system increases the risk of developing chronic meningitis.
Meningitis. Alright, let's get started by talking about what is meningitis. Well, meningitis is inflammation or infection of the brain, spinal cord, and surrounding neurovascular structures. Now, meningitis can be acquired from both community and healthcare settings. The most common pathogens of meningitis include strep pneumonia, Neisseria meningitidis, Listeria monocytogenes, fungal and viral causes as well. Strep pneumonia is generally seen in patients who are adults, specifically patients who range from their mid-20s to about mid-60s. Neisseria causes meningitis in patients from their late teens to their mid-20s. So basically, patients who are young adults are affected by Neisseria. Now, Listeria affects many different types of patients, but generally it affects immunocompromised patients. So patients who have HIV or have been on chronic prednisone use for some reason can generally be affected by Listeria. But most importantly, Listeria affects our elderly population. So for those individuals who are greater than 65 years old are generally affected by Listeria monocytogenes. And like I mentioned before, you can also have rare fungal and viral causes as well. Certain populations are predisposed to meningitis, so patients are immunocompromised. So if you've had an organ transplant and you're on immunosuppressants, if you've had HIV, if you have an autoimmune disorder, you are predisposed to developing meningitis. So always consider that if you present with altered mental status in an immunocompromised patient. One of your differential diagnoses should be meningitis. In addition, complement deficiency can also predispose someone to meningitis. Complements are factors in your blood that help defend your body against certain bacteria. The way they do this is that these complements form complexes and punch holes within bacterial cell walls. So if you don't have C5 to C9 complements, you can develop repeated Neisseria meningitis infections. In addition, patients with history of spinal procedures such as injections, VP shunts, or trauma to the spinal cord are also predisposed to developing meningitis. As you may know, the news has been inundated with numerous cases of patients developing fungal meningitis from compounded steroid shots that were used for spinal cord injections. As a result of these infected steroids, many people have gotten sick and have even died because of the fungal infection present in these steroids. So let's talk about the symptoms of meningitis. There is a triad of symptoms for acute bacterial meningitis, and this includes when patients develop fevers, nuchal rigidity, or means neck stiffness or neck tenderness, and a change in a mental status. Other symptoms that you'll see, especially with other causes as well, include headache, lethargy, seizures, as well as focal neurological deficits. Now, realize that in patients who are immunocompromised or older may present atypically, so they may just have lethargy or they may just have a headache. So it's really important to tease out the history, see what the risk factors are, and assess their patient for the risk of meningitis. Here's an interesting physical exam finding associated with meningitis. It's called palpable purpura and a petechial rash. These findings are commonly associated with Neisseria meningitis. But note that these are very nonspecific findings. Other physical exam findings include nuchal rigidity, which again is neck tenderness and neck stiffness. In addition, we can do certain signs by bending and manipulating the patient to elicit whether the patient has inflamed meninges. One of those are called Koenig's sign, others called Brzezinski's sign. Now these used to be very popular in medicine to do, but the actual specificity and sensitivity has been kind of overrated in the past. But it's important to know how to do them. So Koenig's sign is essentially when you have the patient flex their hip, and then when their hip is flexed, you try to extend their knee. You will see quite quickly that the patient will scream out in pain. The reason why is that both these signs are testing for inflammation of the meninges. And whenever the meninges are stretched, especially when they're inflamed, the patient will have a very quick pain response. So by extending that knee with the hip being flexed, you're extending that spinal cord and all the meninges and dura around it, and that causes the patient to have pain. Second, you have Brzezinski's sign. So essentially with Brzezinski's sign, you lay the patient down, you flex their neck, and you'll notice they'll automatically flex their hip. And the reason why, again, is their meninges are inflamed. As you flex their neck, you put more tension on their dura, spinal cord, all the neurovascular structures. And because of that pain, they have to flex their hip to relieve that tension in their meninges. So these are two signs you could do, Koenig's and Brzezinski's sign. Again, these should all be done in the light of their clinical history and the probability of them actually having meningitis, because other things could cause these to be positive as well. Now let's talk about the causes of meningitis. So we have Streptococcus pneumonia as one of the causes. Again, mostly seen in mid-adults. It also occurs in patients who are asplenic, so patients who have sickle cell anemia, have had autosplenectomies. They need to have the pneumococcal vaccination because they're predisposed to Streptococcus pneumonia infections. Other immunocompromised patients are also infected, so patients with HIV or patients with multiple myeloma or other cancers can also be predisposed to developing Streptococcus pneumoniae. Now, Neisseria meningitis, now, like I said before, is associated with crowding. So areas like dormitories and military barracks are very commonly affected. Now, that's why we see Neisseria meningitis specifically in younger adults, so those who are living at college or those who have joined the military tend to be younger in age, and that's who are affected by Neisseria meningitis. In addition, complement deficiency, like we talked about before, C5 through C9 deficiency patients are also predisposed to Neisseria meningitis as well. Also, we have Listeria monocytogenes, which is associated with contaminated foods. It is an intracellular pathogen and generally affects patients who are immunocompromised in some way. So patients, again, who have HIV, cancer history, who are on chronic prednisone or other steroid use, as well as the elderly. So keep those risk factors in mind when thinking if a patient has meningitis and what is actually causing it. The last class of infections we'll talk about are gram-negative bacilli. So this is commonly associated with head traumas and neurosurgery. If you have those risk factors in the history, you may want to think about gram-negatives as a cause of the meningitis. Another example would be strongyloides infection. So strongyloides is actually a parasite that you commonly encounter in Asian countries. When you have a significant strongyloides infection, because of the significant amount of hypersensitivity reaction and inflammation, the pores that normally block things from entering your meninges open up. So gram-negative bacilli are commonly co-infected with strongyloides, and you develop a gram-negative bacilli meningitis as well. So it's an interesting association that you may see there as well. Now let's talk about the meningitis workup. So if a patient comes in, you have a high clinical suspicion for meningitis, what should you do? So basically right off, get some lab work. So you need a CBC with a differential to look at whether they have a leukocytosis, anemia, thrombocytopenia. You also want to get a Chem 10 to see if they have any associated electrolyte abnormalities. It's very important to obtain blood cultures because if they do have a bacteremia, then if you identify it with the cause of that bacteremia, that's likely also causing their meningitis as well. Now, CT head is kind of a controversial issue in the sense that when do you get it, when do you not? Now, for testing purposes, if you encounter a meningitis patient on a test, if they do not have any focal neurological deficits, then you do not need to get a CT head. The reason is the CT head is there to look out for evidence of increased intracranial pressure, masses, things that would lead to risk of herniation if you were to do a lumbar puncture. Now in reality, we tend to obtain CT heads in all patients who have a history that is consistent with a meningitis picture. The reason why is that if you were to do a lumbar puncture, even though they have no focal neurological deficits and they were to develop herniation, it's such a catastrophic complication that could easily be avoided by obtaining a head CT. So in reality, obtain the head CT, then do the lumbar puncture. In addition, you also want to get, like I said, a lumbar puncture, but obtain appropriate CSF studies. And we'll go over which CSF studies you should get and in which situations to make sure that you're ordering the appropriate tests. So here we'll go over the different tests and their values and how to identify the different types of meningitis based on these tests. So things you want to look for are color, opening pressures, protein, glucose, cell count with differential, RBC count, and cytology when obtaining your cerebrospinal fluid. Color is normally clear and colorless. Now, opening pressure is the pressure you obtain and measure when you initially enter the CSF space. So it's generally normally 7 to 20 millimeters of water. But note, you should only obtain this of patients in the lateral decubitus position, because if the patient's sitting up and bent over, this can falsely elevate or change the opening pressure. Protein should be obtained. It's usually less than 50 milligrams per deciliter, which is normal. Glucose is generally less than 80 milligrams per deciliter as normal. And your cell count with differential should be about 0 to 5 mononuclear cells are present normally. Now, in cases when there are a lot of RBCs present in the CSF due to traumatic tap, there's a correction factor you can use. So you basically subtract 1 from the WBC count for every 700 RBCs that are present in your tap. But normally you should have no RBCs present in your CSF studies. And finally, your cytology should have no abnormal cells, because abnormal cells would indicate a malignancy or cancer.
Diagnosis. Doctors do magnetic resonance imaging MRI or, if MRI is not available, computed tomography CT of the head, followed by a spinal tap lumbar puncture to obtain a sample of cerebrospinal fluid. The cerebrospinal fluid is sent to a laboratory to be examined and analyzed. The results can usually enable doctors to distinguish between chronic and acute meningitis.
Meningitis. Introduction. Meningitis is a very serious infection of the fluid that surrounds the brain and spinal cord. Meningitis can be fatal. However, if found early, it can be treated. This patient education program will help you understand what causes meningitis and how it can be diagnosed, treated, and prevented. Meningitis. The brain and the spinal cord are the command centers of the body. They allow us to speak, hear, understand, see, move, feel. A clear fluid called cerebrospinal fluid, or CSF, surrounds the brain and spinal cord. CSF is a clear fluid that looks like water. CSF acts as a shock absorber and protects the brain and spinal cord from injury. Membranes called meninges protect the brain, spinal cord, and CSF. Meninges help prevent CSF from leaking to the outside. Meningitis is an infection of the CSF, the fluid surrounding the brain and the spinal cord. People sometimes refer to meningitis as spinal meningitis. Causes. Bacteria and viruses are organisms that can infect the meninges and CSF. When a virus infects the CSF, it is called viral meningitis. When bacteria infect the CSF, it is called bacterial meningitis. Bacteria are bigger than viruses under a microscope. It is important to know whether meningitis is caused by a virus or bacterium so it can be properly treated. Viral meningitis is usually less severe and may need no specific treatment. Bacterial meningitis can be quite severe and may result in brain damage, hearing loss, or learning disability if not treated early. For bacterial meningitis, it is important to know what type of bacteria is causing the meningitis. Antibiotics are essential in treating patients with bacterial meningitis and can also prevent some types of bacteria from spreading and infecting other people. Symptoms.